Thank you, everyone, for joining us tonight. Thank you, Dr. Jones, Dr. Reddy, for taking time out of your schedules to share more about your program. Happy Friday, everybody. And my name is Laura Miner. I am the current Western Regional Representative for EM and the incoming Vice Chair for EM. In the chat, in the webinar chat, hopefully you guys can view that for the students who have joined us today. If you're not already an AEM member, please become one. There's tons of student benefits, tons of ways to get involved. We always have stuff on our social media. So I put a link for our social media as well as a link to all of our student benefits. And then my email is in there as well. So if any of you have any questions throughout the series or any questions about AEM in general, please feel free to reach out and I'll happily answer those. So thank you all again for joining us for our third showcase of the series with OHSU. I'm really excited to be hosting you guys. So we're going to keep the same kind of format. So I'll let you do whatever form of presentation you'd like to, Dr. Jones, and then we will open it up afterwards for a Q&A for the students. And so if y'all would like to start with some introductions, I'll let you do that, and then we can just jump into the presentation.
Okay. Hi, everybody. My name is David Jones. I am the OHSU Emergency Medicine Residency Director. I've been in this role for the past 5 years now, and really was honored to be invited and excited to be here. And I'm going to turn it over to Dr. Lauren Reddy.
Hey guys, I'm Lauren. I'm one of the second years in the program, Rising Chief for OHSU. And yeah, happy to field questions.
And I'm going to take just a moment here, and I'm going to tell you real quick about our program. I imagine that there are students from all different levels that are part of this, and many might not know much about OHSU. I would like to introduce you to Portland. We are the only emergency medicine residency program in Portland and one of just a few civilian programs in the Pacific Northwest. This is our hospital. We are actually on a hill. And one of the ways that sometimes people get to us is by coming by tram, which is always a delightful thing to go up and down. The School of Medicine's at the bottom of the hill, hospital's at the top. So every time we have a sim day, we travel down to the bottom of the hill, and it's always a good time to ride down there. From the other direction, you can see several mountains as part of the Ring of Fire, as it's known. On the West Coast, there's a lot of volcanoes that we can appreciate, and the city of Portland. It's really a beautiful campus. We are also, besides for being the only residency program, we are the only quaternary care center in the state. So we wind up seeing pretty much everything in a catchment basin for Oregon, Western Idaho, Southern Washington, and Northern California. So you may at OHSU see the 2 transplants and 2 cancers from the resulting immunosuppression patient. And next door have a houseless individual with chilblains on his feet. And next door to that have the CEO of Intel, who's got a bad gallbladder and everything in between. We have at OHSU both an adult and a pediatric emergency department that our residents are involved in. And we are involved. We try to have a good time both in the emergency department and out of the emergency department. We have regularly training labs and opportunities for people to learn how to be emergency medicine physicians. This is a picture of one of our trauma bays with a little bit of a funny perspective now that I look at that. And this is actually a class photo from a couple of years ago. Actually, Lauren, your class is not in this one, but the seniors are. But this is our graduating class, and this is Lauren's class. We send our residents to 3 regional or national conferences. As interns, they go to ASEP. As second years, they go to OSEP, the Oregon College of Emergency Physicians. And as third years, they go to the SAEM conference. And here's a photo of that. And we are, like I said, we see everything that comes through the door. We have the Oregon Poison Control Center. Our residents spend some time in poison control. Our residents spend time in the hospital and multiple other hospitals. This is a picture of a training session that we have. This is another picture of a simulation session that we had, particularly preparing for a disaster. This is one of our hospitals that we rotate at, the VA. We rotate at 6 different hospitals. OHSU is the main hospital, the VA, the Portland VA. This is Providence St. Vincent's. This is Kaiser. This is Kaiser. It's a mock-up of one of the Kaisers. Here's another one of the Kaisers. This is Columbia Memorial. We rotate out in Astoria at a critical access hospital. We also rotate at Legacy Emmanuel Hospital, and Portland is fantastic. Please, without further ado, what would you like to know about our program?
All right. The students should be able to, if you're If you want to turn on your camera, great. You should be able to speak, but if not, I can allow permission. But everybody's welcome to put a question in the Q&A as well. I can monitor that. But while that's going on, Dr. Reddy, I would like to hear from you to hear what attracted you to OHSU, how your journey has been through OHSU.
Yeah, I had a abnormal path to emergency medicine. I did 2 years of orthopedics. And then during that training, in ortho, being a consultant, you spend a lot of time in the ED. And a lot of my colleagues were hankering to operate, and I found I was preferring to do ED procedures, reductions, spend more time in the ED. So I started doing some ED rotations and ended up switching, I guess, 2 years ago. So technically a PGY4, and obviously using my orthopedic training in the emergency department, but very happy with my switch. And I can put my email in the chat for anyone who, is coming from a different path and wants to chat. I was looking for a place that offered outdoors with great training and was hoping to be close to my partner as well, who is in medicine. I feel like Oregon offers such a great combo. You have the ocean an hour away on the coast. You're 20 minutes from the gorge, which has amazing hiking trails and the river. And then I live to ski, and Mount Hood is about an hour and a half away with 3 really wonderful ski resorts open from, I think this year, November until May, which is wild for an East Coast skier like me. And then I found that being one of the few kind of level 1 facilities without a ton of other programs, it offers something a lot of other big cities don't. I'm originally from the Massachusetts area, and in the Boston area, there are probably 4 to 6 EM programs and many hospitals. And I find that often breaks down the acuity and the volume because everyone's getting diverted to different centers. Whereas I think here, as DJ mentioned, you seek like quite a range of acuity and often like a lot of volume. Sometimes if there's like a scene call, we'll get 3 to 4 traumas at once, and you'll have to have a lot of autonomy, whereas your attending might go to one room to manage and you're in your own room kind of head of the bed leading it. So I think having that exposure early on was really great. And then as someone who's not sure what my practice style will be yet, I think the variability of exposure we get is really valuable. It was a quick scroll through all the different hospitals we go through, but it shows that we see a lot of different practice styles. So although we rotate at an academic center, we also do a month in our second year, and I'm doing a month in my third year at Astoria, which is a coastal small center that's affiliated with OHSU, but is a lot more austere. And I think having that experience can make you think a little more critically about your decisions and what resources you have. Kaiser and St. Vincent's have a lot of continuity of care with their patients, and you work on your volume at those centers or hands-on orthopedic reductions or cardioversions. So I think each of our rotations offer a little bit of a nugget and guide you on what you're looking for in your job and when you graduate. So that's one of the things I've been appreciating in my training. So
Thank you. All right, we got some questions. First one, where do people go after residency at OHSU? Into the community, fellowship? Also, just an FYI, the chat is disabled, so we can't see stuff. Okay, thank you for the FYI. So we'll focus on so where do people go after residency at OHSU? And then is that into the community and fellowship?
So roughly about a third of our residents in any given year go into fellowship. And those fellowships range from critical care to palliative care and everything in between. The one that we really haven't gotten yet that I'm still searching for my first fellow is aerospace medicine. Someday I want to send a grad of mine up into space. That's the target. But of the 2/3 that don't go into fellowship, about 80% wind up staying in Oregon. So that means that 1 or 2 wind up leaving the state each year. And they are all over the country. We have a 40-year alumni. And so we've got people pretty much everywhere you might want to end up. A lot of the ones that do stay in Oregon do end up staying in the Portland area, although that's not everybody. And so there are people that wind up in rural hospitals in Grants Pass, in John Day, in Pendleton, or they wind up in the cities and they're in Salem and they're in Eugene and they're in Portland. So we successfully produce grads that go everywhere.
Next question. I know you mentioned a rotation site in Astoria. Can you talk more about opportunities to train in more community settings?
Lauren, you want to address that one?
You might know a little bit more than me, DJ, but
Okay.
for Astoria, so that's definitely, I wouldn't even say like community. I would call it rural, just based on the resources. We do a lot of community rotations at St. Vincent's Hospital in Portland and Kaiser. And then I would say Legacy Emmanuel. So those centers are less resident run and more provider run, which gives us a great opportunity because it means you're one of the few learners at the center. So you're getting to do a lot of procedures, and you might be seeing some patients will attending, and then someone comes into the doc room and they're like, hey, we have this really cool thing in this room. I'll write the note, come join me, which I think is really great. And then in your third year, you do an elective and a selective. And the 4-week rotation could be community, it could be rural, it could be Japan. I think two of my co-residents are planning on Hawaii this coming year. I'm doing in Astoria, so rural. So that's your opportunity to step outside the box and rotate in a center that can either help you find a job or do something cool that you won't get to when you're an attending.
All right. Another question for you, Dr. Reddy. Any unique challenges in moving from the East Coast out west?
The drivers are so slow here. I can't stand it. People drive like 50 on the highway in the passing lane are just having a great time. And everyone at four-way stops will defer to another person, even if they're there first, which I find is dangerous. That's all it is. I think my parents are out east, so it's definitely hard not seeing them as frequently. Alaska has a lot of great direct flights. There's a direct flight to Boston. There's a direct flight to Miami now on Alaska from Portland. I find the culture is a lot less hierarchical. Not many people wear white coats. Attendings are willing to teach you. I think there's less hostility in the workplace. And I think there's more emphasis on learning rather than some form of passive aggressive punishment that can come with teaching. I find faculty much more willing to teach. What else? Yeah, I think the access of nature is also something I really value out here. I think being in Boston or in New York, you want to go skiing, you want to do a weekend in the mountains. It's an hour plus drive to get to most places where there's no elevation. So I think having that access has been really valuable. And I don't plan on going back east, but I think it says something in that when I was an orthopedic resident, not on the West Coast, not many people visited. And now that I'm in Portland, I have someone coming like almost every month wanting to explore and check out this coast. I have enjoyed my transition. I'm not like West Coast, but I'm heading that way.
All right. What kinds of characteristics do you guys look for in applicants, and what makes a successful resident at OHSU?
I can answer that one. The successful resident, we have all of the resources, but we really believe that you at this point should be an adult learner. And so we give you access to the resources. We will give you access to the coaching, but we don't hold your hand to becoming an emergency medicine physician. You are expected to study on your own. You're expected to learn on your own. And we're not going to give you the weekly quiz to direct you into what you should be learning. We're going to give you the guidance. We're going to give you the coaching, but we really want you to take control of your education. And that extends from just these particulars of emergency medicine to everything from your scholarly project to your career exploration, that we have all of the resources and we make them all available to you. But I'm not going to force you to go, and I'm not going to force you yet. I soon will start forcing you to go to work at a fun run and do some crowd medicine and athletic and some sports medicine stuff. And if you want to get real involved in EMS, that's great, but I'm not going to force you to do more than just that introductory stuff. And so you really have to be willing to step up and run your own education as opposed to what most medical schools do, which is give you a syllabus and say, here, this is what you need to learn. And then you learn that. And then they give you another one and say, learn this. We say, this is emergency medicine. Learn that. And then we help out with that and help guide you through that. What do we look for in applicants? If you've only won one Nobel Prize, like you're borderline, but if you've won two, we'll certainly consider you. What I really want is I want somebody who's committed to something, who's dedicated to something. I want to see someone who is clinically excellent, yes, but also has worked with a free clinic and made that experience better, who's worked on a research project and completed that, who has designed an educational endeavor and worked on that. And I want to see that commitment. I'm not necessarily looking for somebody who did 50,000 things for 6 minutes each. I want somebody who's done three things and really got into them and did them well and has committed to making things better and working on improving whatever it is that they got involved in. So those are very 30,000-foot views of what we're looking for residents at OHSU.
All
And to
right.
bounce off,
Yeah, go ahead.
although there's not like a ton of hand holding, I think as you go through residency, things will fall into place sometimes. For example, we're all assigned mentors, and I like research, but I don't seek it out a ton. And my mentor and I kept meeting, and then she forwarded me an email and was like, "Hey, I'm working on this book chapter. Do you want to join?" So I think our faculty does a really good job involving us in things if we want to. So I think there's a lot of kind of natural progression of connections leading to things such as that. Or I worked with a fellow on shifts, and he was like, "I'm doing this project on callbacks," and it led to my scholarly. So I think things happen super organically here, so that you don't think you're progressing your career, and then you're like, "Oh my gosh, I've checked my scholarly project box early. I have now published a chapter that I wasn't expecting to do." So I think there's a really good support system it's there present and supporting you throughout your time. And we do get assigned weekly questions sometimes, so that's also helpful. There is some prompting, but a lot of it's self-driven.
Okay. Next one. I've heard rumblings about EM residency applications switching from, I call it ERAS, some people say ERAS, to Residency CAS. What platform will be best to apply to your program?
Most likely it's like those rumblings are not just rumblings, they're probably true. Almost all of EM is going to go to Residency CAS here in the next year. Look out for that. And what platform? There's only going to be one Residency CAS. So
Thanks. And then back to the chat complication. I don't know what's going on with that. So if y'all go to your answered, like in the Q&A, I was able to respond to somebody, but I can't put my own question. So hopefully y'all can see my contact information through that. Okay, next question though. Do many of the residents have families? Is the culture family friendly?
yes, just a couple years ago, we actually led the emergency medicine led OHSU GME with the most babies in 1 year. We had a lot of people with families. We have people coming in with families. We have people that make families while they are in residency. The timing of residency is such, the timing of medical school and residency is such that this is actually a prime time for family development and family growth in your life. And so it would be silly if we were not helping you with that type of aspect. I firmly believe that what I'm doing is not just preparing you for the job, but preparing you for the career. And having your family is part of the success of your career. And whether it is some policies that we have around parental leave or scheduling attempts that we make for keeping third trimester pregnancy out of night shifts, we really try to be family friendly as we move forward. And I think, Lauren, you can weigh in on how that works from a resident standpoint.
Yeah, I do not have any children myself. Two people in my class have children, and they're involved in when we went to Bend for our conference, one of them brought their daughter and she went snowboarding, and it was absolutely adorable. The class above me, two of the guys are either on mat leave or pat leave or recently went on paternity leave. I feel like our program does a really good job of just expecting it and not putting a burden on other residents when that happens. I think in the incoming class, we do have at least one parent with children. I think it's becoming more and more normalized. And I think there's a little bit of everything. When you have 3 years with 11 per year, there's some people who are coming in single, some people with partners, some people with children, all different stages. So I think that you'll find that in each group, there's like little factions of people. My co-resident Jeffrey, he obviously has a child at home, so can't come out in the evening sometimes. There are two people sometimes who are always down to hang out. So I think you'll find that no matter like what stage in life you are coming from, there's people in our program that are of similar background.
Okay. Do you feel you are appropriately compensated for the cost of living in Portland? How is housing and transportation?
I can talk about this. I'm on the resident union, and I know that a lot of hospitals are moving towards having resident unions just because resident salary is garbage. But I think we're pretty well compensated, especially compared to most West Coast schools. I think we're better than most California places, despite it being much cheaper here. For housing, there's 4 sections to live in Portland. There's a river in the middle, and then sorry, this is gonna be mirrored because I'm on the screen. Perfect. And then OHSU is like southwest. I live in northwest. And then there's like the east side's more residential, probably a little bit more affordable. I live in an apartment building. My rent is $17.50 per month. I think it's more than affordable with our salary. I think I take home about 2,100 every 2 weeks. But that's like obviously accounting for all the taxes we pay as well. We just had, man, I just printed it out. Let's see if I think I have it on my computer. We just negotiated for a salary increase. If I can find it, and it's graded. So each year goes up by 15%. Here we are. Okay, I'm going to throw some stats out once I pull up this document. Okay, so we have a new contract. It's from 2025 to 2027. For that, we now have a housing stipend. It is $3,500 over the next few years. It was $2,000 when I got here. $1,200 for relocation reimbursement. So that is when you move, paying for your U-Haul, your gas. You just submit a request for that and just gets added to your account. For raises, it's 6.5% and then 4.5% for the second 2 academic years. Education material, $1,000 stipend. There's a $125 a month chief resident stipend. Really excited for that. But yeah, our salary is pretty impressive. It's definitely Googleable. I think I'm probably getting 76,000, maybe a little bit more, but it's very manageable. Portland is quite an affordable city for the West Coast. I would say probably one of the cheap. I think it's cheaper than Seattle, cheaper than basically anything in California. So yes, I'm going to a nice grocery store and feeling okay about it. I'm not worried about buying healthy food or like paying for meat or anything. And my neighborhood feels safe. So I think it's reasonable. I personally do not pay for parking at the hospital. I bike to the tram, that thing that DJ showed in his picture, and I get $3 a day for using the tram. So instead of losing money by paying for parking, I make money by biking. And then most of our shifts, if we're working in the evening, parking is free anyways. So like I work tonight, and since it's after 5 p.m., I get free parking. So I think that adds to my wellness. We also get a food stipend, which is nice. Works in a couple of the cafeterias in the hospital. So
That was a great answer. I feel like a lot of students don't always get that much transparency, so that was great. Thank you. Okay, next question. What opportunities are available for community outreach and involvement in the city and surrounding areas beyond working in the hospitals?
So we do have all kinds of opportunities for working on being a physician in a fun run, being a physician in the marathon. You can get involved in Portland Public Schools, the state wrestling tournament. You can get involved in some of the high school and collegiate football games as an individual. As you get a little bit further advanced, you have an opportunity to get involved in the free clinic, the Bridges Clinic, that's mostly student run. You can get in there as a resident. And as you get even further advanced, you can get involved with Portland Street Medicine. The emergency medicine is inherently a reactive specialty. And so we don't have a lot of health fairs and things like that we host. Because I got to be honest, if you come to me and you're like, I have high blood pressure, I'm like, follow up with your primary care doctor. And some of the things that, say, family medicine might be able to do, we would just not be very good at.
Okay. All right.
regarding
The rising M. Sorry, go
I'll
ahead.
just add to that. One of our attendings works with Portland Street Medicine, and I think there are opportunities there to either do research on their data or get involved with that attending. And then, as DJ mentioned, people are always emailing out about different events. So one of my co-residents and a couple of my attendings ran the Portland Marathon this fall. and a couple of us worked in the medical tent at the finish line and got to cheer people on and also help with different things that went down. And then last year, I volunteered at the high school state wrestling tournament, and you have things from syncope to elbow dislocations to clavicle fractures. Yeah, finding opportunities like that. And then, yeah, you could probably always explore yourself and bring it up to DJing. Probably would be fun too.
As a rising M3 without a home EM program, any actionable advice for succeeding on EM rotations?
When you are working through, so residents and attendings have different things that they look at when they look at a student. The residents typically look at how are you to work with, do you lighten their workload, things like that. The attendings will often look at what do you know and how do you present that. For success, you really want to know who is evaluating you and how is that evaluation going to happen. If you're working with a resident, like making sure that you keep on your labs, and if you can put together the discharge instructions or something like that, if you can gather up the supplies to go and close that lack, those are things that are going to really make their life easier. And that is going to reflect very well for that from that standpoint. From the attending standpoint, a lot of times it's going to be based on your presentations, your differential diagnosis, what your plan is. And one of the things that I really encourage you to do is when you are making your plan, which is one of the places that med students struggle the most, don't just work on the diagnosis. Don't forget the therapeutics. What do you need to do for pain? Does this person need antibiotics right away? Does this person need fluid resuscitation? Do they need something for nausea? Is there an antidote that they have? And if you create a good differential diagnosis and then your diagnostics are all reflective of that differential and you have a plan around those therapeutics, you have a very good initial emergency medicine plan. And so you can really stand out by addressing both the questionable medical stuff that the patient comes in, as well as making them more comfortable by treating the therapeutics. So really keeping that in mind as you are crafting that plan.
Yeah, having someone willing to do lac repairs without needing a ton of supervision. It's so wonderful. So, yeah, just as DJ mentioned, like having someone who is thoughtful, easy to work with, I think is key. Can you be a team player? I think that's probably the most important.
Y'all can keep sending in those questions. This has been great. But as we wait for some more to come in, I'll hit you guys with some questions that I have written down. Dr. Reddy, for you, I was wondering how you become a chief resident.
So it's application process. But I think not everyone applies. As someone who I think if you start playing kind of a leadership role earlier on, it points you in that direction. My co-chiefs, Aaron and Zach, we led our journal club this year as second years. So first Tuesday is a monthly event that we have the first Tuesday of every month. It's protected time from about 6 to 8 p.m. on the first Tuesday of the month. If you're in an ICU, you get excused early. If you're on a night shift, you don't start until after. And it's time for all residents to have off and gather and learn about a topic, perhaps over beer. It's purely resident driven. So the three of us have complete autonomy over what gets planned. There are a couple kind of yearly activities that we really like to continue just because they're enjoyable. So our July 1st Tuesday is usually water themed, and we rent pontoon boats, usually like about 4 pontoon boats. And we go down the river, we do some swimming, we learn about some water related topic like drownings or something, and we have food and drink and enjoy the summer weather. In the fall, we do a really great one with our EMS colleagues out at Banks Fire, and we get to kind of work in the field. So talk to them about fire response, extraction from vehicles. We got to use like the jaws of life and peel windshields back and like load people on backboards out of cars, raising and lowering people on ropes, a variety of things. That's usually something we look forward to too, because it's outside and usually at the end of the summer. And then we often get a lot of kind of faculty spotlights. In February, We did it at a venue and had one of our pediatric attendings talk about cardiology and peds patients and abnormalities because it was February, so hearts. This past month, we did one of our education fellows does a lot of work with social justice, MPH stuff, education. So she facilitated discussion after watching a video, and then it turned into karaoke, as it does at one of the venues downtown. And then in May, we have Sono Game. I realize I'm totally going off your question in a very different direction. But in May, we have Sono Games, which one of our ultrasound faculty leads. It was really fun last year, but we have different stations and it's a competition. And you form a team and you do ultrasound games against your colleagues. And then I came in second last year. It was really fun. And there were prizes. And the theme is, I think it's pirates themed this year. And costumes are encouraged. So we try and do something fun. It's really great to. I came here not really knowing anyone in Portland. So most of the people that I consider my closest friends are in residency. So I find similar to Wednesdays where we have our grand rounds, it's a great time to gather with your friends. So that is one thing I do that I think kind of led to the chief role. As someone who lives here alone and has a lot of free time on their hands, I think I'm pretty involved in the program. And yeah, I really like my colleagues. I think I enjoy being with them. I enjoy planning. I'm pretty scheduled and oriented. The chief role, I know some places have different chief roles for different parts, whether it's like a social chief, a scheduling chief. But in our program, we all share the roles. So like we all work on the schedule together. We all work on communicating with other departments, which I think is a nice way to do it. So we all share the.
That was a great answer because my next one was what different fun activities do you do? So you answered both.
Those are like fun work activities.
Yeah.
I personally just signed up for a half marathon today.
Exciting.
At the recommendation of my APD, who is doing the 50K of the same race. And I'm sweating just thinking about it because I have not been training for this and it's next month. But we have Forest Park here, which I can actually look at in my apartment right now. It is one of the largest parks in a city in America. It has 80 miles of trails. It is my oasis. I love it. And they're doing a half marathon and trail race and 50K next month. So I think a lot of us do like outdoors, as EM does. Some of us, like Emily, one of my co-residents, has asthma and it's just not her thing. So she prefers like gardening and knitting and is very happy doing indoor activities with her cat and her dog. But I think there's like enough, as I said, 33 people, you're going to find people to do things with. Two of my co-chiefs really enjoy running, so we'll do casual runs. Two of my friends from my class really love skiing, so we'll try and overlap for ski days. One of my cousins likes climbing, so we'll climb occasionally. I think everyone likes eating, so Portland's a pretty good food scene, so we'll usually message out to the group chat to see when people are available to grab a snack. So good breweries, good food, very cute neighborhoods, and pretty great weather, especially in the summer. It's 80 and sunny every. And I, as someone, I don't really mind the rain, but it wasn't that bad this year.
Okay, what are some of the highest needs for the patient population in Portland? I know you mentioned something about social EM earlier, so do you guys have the mobile unit that you send out? We just had our scientific assembly in Miami, which was a lot of fun, but we got to hear from a lot of different PDs and it was fun hearing all the different regional like highest needs. So I was curious what the patient needs are out in Portland.
DJ, you might be able to talk to this because you've lived here longer than.
I think that we have, so the West Coast is interesting. The I-5 corridor from San Diego all the way up to Vancouver, British Columbia is a easy pathway for parties and drugs. And so we wind up getting people that will travel from each city to use the drug du jour, or I don't know, du jours of the day, drug de city, and explore that. So we wind up getting a lot of drug use. And we have a very heavy fentanyl use and we have a very heavy meth use in the city. And so we wind up seeing a lot of that. And as a result, we wind up training our residents in starting people on Suboxone and medication assisted therapy and stuff like that. I got to be honest, I have probably a 4% success rate in actually getting in my offers of starting someone on Suboxone and getting them to accept, but it is a real thing. And that's the medical side. I think actually one of the bigger issues that we have is that Washington and Oregon are two of the states that have the fewest hospital beds per capita. And so we have a increasingly ill population that don't have necessarily always the place to go. And the kind of national boarding crisis is hitting us pretty hard. And we're seeing patients that are either waiting in the emergency departments or delaying care until they have to come to an emergency department and are much sicker than they necessarily otherwise would be, were they to engage with the healthcare system earlier. But because of kind of this, what at the time was a very intelligent choice, expanding Medicaid and investing a lot of that money into primary care, that was very intelligent until the pandemic hit and delayed all the primary care. And we're still catching up from people not getting the preventative medicine that they really needed. And as a result, their COPD is under less control. Their heart failure is under less control. They are at higher risk for stroke. They're at higher risk for heart disease. And we are seeing all of that, which does, you might argue that from an emergency medicine trainee standpoint, that's great. You get to see all these people that have all this disease. But from a societal standpoint, that is really challenging, that we're facing a critical illness glut that we are also running into at the same time that we have just a resource shortage.
Okay, so the hot topic in emergency medicine are I will say, potential changes happening with, ACGME. Do you see any challenges with your program with a transition to 4 years or with any new requirements that may come?
I mean, I'm going to give two answers to that. Yes, of course there are challenges. It is a big change. However, I think that we are actually very well positioned to handle these challenges. If the transition for one of the things that I've realized as I look at the kind of concerns that were raised by the ACGME is we are not one of the we're not one of the programs that is having the problems. Whether it's our first time pass rates, whether it is our patient touches, whether it is our graduate success, we're not having a lot of those problems. So some of the like fundamental changes that are being referenced, we've actually got some of those. And yes, it's going to need us to we're going to have to get somehow some more neonatal touches and things like that. But we will be able to do that. Expanding to 4 years is going to change things. If we do end up expanding to 4 years, not only is there that, but there's going to be repercussions throughout the hospital when all of a sudden our EM residents, who are very desirable residents because of what they can do and what they are willing to do, are not spending time in the ICUs and not spending time on the different services and stuff like that because there's now fewer residents per year. That is going to have repercussions that resonate throughout the hospital. But that being said, if and when the time comes that we do make this transition with these new requirements, we will be in a good position to make that transition. And we don't know that it's happening, but we're planning as if it is. So we'll be ready if they do it. And if not, then we'll just keep going and we'll figure out anything that we thought, oh, hey, that was a good idea. We should have been doing that. We'll just incorporate that then.
I also think it's a good sign that we're a 3-year program, and although some of our residents do fellowships, it's not super common. And I think sometimes with 3-year programs, people will use fellowships as a crutch to bridge them to their career if they're worried about practicing independently. And I find that our 3rd years are really comfortable just going straight into practice.
For any of our DO students who might be joining us, do you recommend that those students take both STEP in addition to their level exams to be competitive?
When the USMLE Step 1 went to pass fail, we barely blinked because really what I care is that you can pass your boards, not really what score you have. The score, whether it's COMLEX or USMLE, it tells me that you can take a test, but it doesn't mean that you're going to be a clinician. Some of the highest board scores I've ever seen are on questionable clinicians, and some of the lowest scores that still passed are on great clinicians. So I'm much more interested in what you can demonstrate as a clinician than what you can demonstrate on your boards. Passing your boards is an important part. So if you struggled with it, that is something that we will discuss and we will work on and try to get you where you need to be. But do the test that makes the most sense for you. Don't worry about us.
How do you guys work your traumas with the other residents? Like other residencies, like surgery, anesthesia?
Lauren, you want to take that one first?
Yep. We are head of bed. So I think it might change a little bit going forward just because we share our exam with the trauma resident. Currently, I am at the head of the bed. I am doing airway breathing, stopping as needed. Trauma resident does circulation, make sure there's distal pulses, and then we continue with our secondary and then roll the patient. We do have for I think during the day until 7 p.m. anesthesia comes. Usually they come without a resident, and the anesthesia attending is more than happy to lead you through a difficult airway if it happens to be. I also tend to go in elbows up if there is an anesthesia resident, just because they get airways all the time. And I usually just go to the head of the bed and then defer to them and I'm like, hey, do you mind if I do this airway? Usually they don't care. They step away as soon as it's not a high acuity situation. Anesthesia does come to all full traumas, but again, they're more there as a resource. And once they see that, if we're comfortable with just us and RT, then they'll usually fade away into the background. So yes, I would say we run the traumas, and then it's a shared discussion with the trauma chief / attending on next steps for the patient, like where they go, what imaging is done.
We're discussing with the trauma team right now to move from a kind of segmented evaluation to a trauma doc system where on alternating days, one doc will evaluate everything and lead the trauma while the other does the procedural side of things. That has been proposed. We're figuring out the details, and I would not be surprised if that happens sometime in the near future, but I don't have a actual time frame for it. It will be a change in how OHSU has run traumas for as long as I've been here, so at least 15 years. There'll be some retraining of all of our faculty and a myriad of residents when that comes.
Do you allow moonlighting?
Yes, there are certain criteria that have to happen with moonlighting. Everything from you have to be in good standing, you have to have certain particular ITE scores, you have to have my approval. And typically it tends to happen in the third year if it happens, but we do allow moonlighting. We do not sponsor moonlighting. So any moonlighting that you do is a contract between you and that other group, and we do not get involved.
Okay.
I think one
And then
right
go ahead.
is moonlighting on the BMT service. Yeah, I think it's like a how much free time do you want? Is the money really worth giving up your 1 day off that week or 2 days off that week? So it's something that you decide as you go as well.
For your interns, when they become interns, do you have any like steps to help them with the adjustment to their intern year?
We start the year with an orientation. So the month of July, the residency starts in kind of the second week of June, and there's a lot of stuff. The month of July actually is a ongoing orientation, prolonged orientation. Our interns wind up working about 8 shifts in the emergency department, split between OHSU and the VA, where they really get a chance to put in orders and sign the order. Like at this point, no medical student has signed an order that has mattered. And so this is a chance for them to do that, to write a prescription that is actually going to go out, to do all of those kind of things. And so it really helps them get their feet under them. During that time, we also spend a fair amount of time teaching things like how do you read an EKG? Our assumption is that everybody comes in with a pretty even knowledge base that is pretty empty. Not to be insulting, but we don't expect you to know anything. And so anything that you know is above where we are. We teach ultrasound, we teach EKGs, we teach imaging, we teach suture and reduction, suture and splinting. We teach palliative care, how to have a difficult discussion, recognition of vital signs, all kinds of different things. And then you can take what you learn in those orientation sessions and apply them to your clinical environment. And so really you start the kind of more intense rotations starting in August or end of July, when you've had this opportunity to be in the system a little bit, get to know each other a little bit, get to know some of the faculty, have done some procedure labs and things like that. And then we start throwing you into residency. As an intern, you do start right off the bat. You own your patients. The only patients that we don't want you to see right away as an intern are sexual assault patients and psych patients. Those are trainings that come a little bit later in. Everybody else you can see from the very beginning. How much autonomy you have really depends on the patient. You are probably not going to be running a trauma on your own as an intern, and you're probably not going to be leading a cardiac arrest on your own as an intern, but you're going to be there and you're going to be involved, and that's going to be your patient if that's who you picked up.
Dr. Reddy, if our chat is not working, if you would verbally say what your email is, that might be helpful for students.
It's a really easy email. It is ready to go at ohsu.edu is my email. If people have questions.
I'll see if I can figure out how to work this chat for the next time. Okay, and then we're almost headed towards the end, so if anybody has any last minute questions, please put those in the chat. But as we wait, Dr. Reddy, I had one last question for you. You had mentioned some of the benefits, different stipends. What other benefits exist? And then if there's one thing that you could add that you don't already have, what would it be?
Like when you say stipends, do you mean like perks of employment or?
You had mentioned like some meal stipends, I believe.
Yeah. So I think we're trying to negotiate a little bit better meal plan. This is a problem everywhere, I'm assuming, but right now we're trying to figure out how to avoid getting taxed on meal money because it's considered part of our salary. So we're working on that right now. What else would I wish? I think having the meal money a little bit more established on different rotations. Right now it's challenging because it's for people who work more than 12 hours. So we get a lot of money on like our ICU rotations. When we rotate at St. Vincent's, we get $30 a day, which is actually impossible to use because their food is so affordable. So I was like stocking up on like frozen food. Is there DJ, cover your ears? I don't want you to know how much I was using the funds. It's another hospital's money. It's fine. And then in Astoria, they have cold brew on tap and kombucha on tap. And they have a fridge that is totally stocked. And one of the tendings, whenever you go, always jokes, I want your goal to be like, see how many days you can go without getting groceries by just eating out of the hospital's snack section. We got a lot of good food support. We also have a snack locker, which if you're finishing shift, you're writing notes and you're exhausted at the end of the day, having a locker in the ED that's full of different snacks or like mac and cheese or like gummies is really nice to have. I think one thing that I'm looking forward to that we don't have right now is a space to chart after shift. Right now, I mean, we do have our EM offices, which are probably a 5 to 10 minute walk from the ED, which I can be dramatic about at 2 a.m. when I'm finishing up a shift. And then we obviously have Epic on our computers. So some people prefer to go home after work and just chart with a snack and TV in the background and some mood lighting. I like to get things done before I leave the hospital so that when I get home, I can just prioritize wellness. And I find that when you're in the ED and you're still there after shift, it's very easy to get pulled to tasks. If I sign out a patient and someone's getting a call about them, it's easier for me to just explain to the consultant the patient than have the oncoming team. So I think having a space, which we're working on, that is not directly in the ED, but nearby, so that we can chart with the dragon. We're working on this kind of just down the hallway from the ED. So that is something that we don't have, but I'm looking forward to having.
Nice. Dr. Jones, if costs and resources were not an issue, what would you add?
More space in the emergency department. One of the biggest problem that we have is space limitations, whether it is hospital beds, ED beds, computers, things like that. And so if we had more space, which is really piggybacking on what Lauren said, I would give us more space. Yeah, I think that would be the biggest thing that I would want. And it is more of I don't know, it's a creature comfort more than a curricular necessity or anything like that. But I think it would make everybody feel better.
I think that's a good answer. I think a lot of places would wish for some more space.
Yeah.
Okay, we are just about at our end, so I will let y'all finish with any last words of wisdom or funny jokes, whatever you'd like to share for the last 2 minutes here.
Don't give DJ the platform for attention. We can't do this.
Sure, we can. There's nothing but good ones out there.
Yeah, I would say like enjoy your last year. Coming from orthopedics to EM, I think I finished in May and then switched to EM in June. And I was coming in with very little EM knowledge after being out of med school for 2 years. And I think you can study, but it's not going to matter. You're going to forget a lot of it. And a lot of it's like just hands-on learning while being a resident. So I wouldn't enjoy your time while you have it. I don't think you'll regret taking that trip or skipping the slide reviews before starting. Our month is very gentle for onboarding, and there's a lot of learning, but there's also a lot of time spent with your co-residents. So I would not stress before starting.
I would lean into that a little bit more even and say that as you are towards the end of medical school, this is your one chance to take some of these rotations and learn some of these things that you may never get a chance to do again. Go and don't worry. Some students are like, oh, you know what? I'm going to match it at EM and I'm going to take 5 EM rotations. And I will tell you, I think that's a terrible idea. Go and do some derm and then do some ophthalmology and do some endocrine and I don't know, go see what a pathologist even does. Who knows what they do? And so go and explore all of the things that are out there. You're going to have a whole career of doing emergency medicine, and no one is going to expect you to be a great EM doc when you start. Go learn some other things, experience some other things, and then come in with a little bit of a unique knowledge base and be like, tell you what, Jones, this is what a pathologist does. Say, oh, how about that? I didn't even consider what that was. And explore, learn, be an indiscriminate learner, and just sponge up all the knowledge that's possible. But don't worry about focusing on EM. Focus on medicine and just learning what there is to learn.
Okay. Thank you both so much. We have hit that end of the mark here. The students who have joined us, thank you for all the questions. That makes my job easier too. It makes it more fun. So thank you for typing all those questions in there. And then I will figure out the chat. However, I don't know what's going on there. So we'll have that for the next session, hopefully. But thank you, everybody who joined. Thank you, Dr. Jones. Thank you, Dr. Reddy. We really appreciate you taking time out of your schedules. I know you're all very busy. Thank you. And maybe your residents can go to our scientific assembly. It's in Seattle next year.
That's close.
Yep. Okay. All right. I will let everyone go. Thank you so much.
Bye.
Okay.
Bye.